Okay, formal good evening to everybody. So today we'll have a video session. We'll have some 4 or 5 videos, and uh, I'll, I'll see if possible I'll give chances. The one who wants to practice can put it in chat box that I want to practice. The one who has got exam dates, they'll be given preference. You can put it in the chat box. Okay. So let's start with Murtaza for the first case. I'll start my timer. Murtaza, you ready? I'll start with you.
Okay, sir. I'm ready.
Yeah. So this is your first case. You'll have 3 minutes. You can see how much ever time you want. I'll show you once more.
زي ما بعد بس كلها تلعب خالص كي بيجي تعمل على مدار تبعت.
You want to see one more time?
Okay, sir.
Okay.
Okay.
Time starts now.
Okay, sir. So I can see in this video, I can see a 5 to 6 years old girl, most likely in the hospital setting, who is sitting comfortably on a chair, and she is like blowing up paper, like she is hyperventilating, and suddenly she stops the thing and starts looking, staring upwards, and then which is followed for a few seconds, which is followed by lip smacking type of movement, and she regains her consciousness within like 5 seconds of the events. So most likely it is a case of uh, abnormal movement, and since it has been provoked by after hyperventilation, I would like to keep my first differential of absence seizure.
If could you please tell me any other DDs apart from absence seizures in this child?
So my second DD will be like, it can be a case of daydreaming also, which normally responds when the child is called. It can be narcolepsy also, and can be a case of like partial complex seizures also.
Okay. So, how do you want to differentiate that this is complex partial seizures or absent seizures?
So in the case of absent seizures, it will be like it can be provoked easily with hyperventilation, which is a sign in this case.
Okay.
And second point in differentiation is like the child regains its consciousness fully after the event, which normally lasts for a few seconds. Whereas in the case of complex partial seizures, there can be like the regaining of the consciousness might take some more time in
Okay.
that case. And EEG finding is very characteristic in the case of absence seizure, which will be 3 per second spike and wave pattern.
Okay. So, what all history you want to collect from this child?
So I would like to know the initial onset duration and course of this event,
Okay.
and what happens before any aura like symptoms before or after, where does she gain consciousness after some time or at the same time, what normally makes it better or worse, like hyperventilation is making it better, any sleep deprivation which provocates this event,
Okay.
and how is her developmental milestones, this is very important, and family history of any similar complaints of like this type of activity.
Okay. How do you manage this child?
So in the case of management of this case, I would like to have a multidisciplinary team approach in this case, and which will include my consultant pediatrician, neurologist will be involved in this case basically, and for the management of and I will also like to liaise with the school, because many times they occur with the school and the children might be like thinking other way. So
Okay.
in this case, I would like to have like uh, start anti-epileptic drugs. My drug of choice will be ethosuximide, whereas second line drug of choice will be valparin or even lamotrigine in
Okay.
these cases.
Okay. What is the prognosis? The mother is asking you what will be the prognosis?
So in this case of absence seizures, normally they will have a fair prognosis. They won't have a bad prognosis if it is not associated with any developmental abnormalities. If they are associated with developmental anomalies, they can be like having a slightly bad prognosis.
Okay. Which age group the absence is having a bad prognosis?
So if the absence seizure is like in more than 5 years of age group or less than 6 months, what I remember, then they will have like bad prognosis.
Do you think less than 6 months can have absence issues?
Uh, Very unlikely, right?
Very unlikely.
Right, right.
Okay. Okay. So okay. Suppose the parents have been prescribed medicine. So what advice you will give to the parents when the child has seizures?
So,
General advice.
yeah, the general advice we should see is like the scene safety. In
Hmm.
home, they should not have any sharp furnitures and all, which should be covered with like good clothing, because the child might hit sometimes during these activities. He
Okay.
should not, like, if these children like who are able to ride cycle or driving, they should not be allowed those. If they have been seizure free for at least 1 year, then only. And if they are having these seizure episodes, should be turned on the lateral side, so that
Okay.
secretions do not pool up during the events basically. Swimming and
Okay.
all should be like should be avoided ideally or under strict guidance.
Okay. Cycling.
Cycling uh, cycling is not to be avoided, it can be like allowed
How do you allow?
under strict supervision,
You should
like
wear helmets.
helmets, right, right.
Okay. Any other specific instructions for the seizures management advice?
They should always like the medications which they are telling, the compliance of the medication should be like good, and in those cases,
Hmm.
and school, it should be also liaised with the school, because if the seizure is having and they should have a card for it, because if they are having that seizure, they can be, if they are having seizures, it can be taken care of.
And you have to give the medicines at the same time. You have to have a good sleep hygiene.
Right.
And you should avoid travel in the nights. Okay. And if
Okay.
they are older children, then you have to, and if they are taking drugs like valproate, then you have to be careful with the OCPs.
Right, because it might like need extra doses for it,
Yeah.
interaction.
And if it is an adolescent child, then you have to be careful with the driving.
Right, sir.
Okay. Okay, good. Any other points anybody wants to share? You can type in the chat box. It's a straightforward case of absence seizures. So
The age group, I think I told wrong.
yeah,
Because
maybe. Okay. More than 5 years. That is, juvenile absence is a little bit having a poor prognosis. They have a little bit poor prognosis.
Okay.
Absence associated with some intracranial pathology also has some poor prognosis.
Okay, sir.
Absence secondary generalization also has poor prognosis.
Okay, sir.
Anybody wants to add any other points? They can type. You can type in the chat box if you want, or we'll move on to the next case. This is a very straightforward case.
That's why usually receptive is showing very great competency. While expressive, there is a lag. So now this lag and discrepancy.
I didn't get you. You can just type in the chat box, sir. I'll read that. You can just type in the chat box. Swimming is prohibited. Yes, swimming under supervision is also fine. Generally, swimming is prohibited. Okay. Anybody else? You can just type it in the chat box. Then Sheikh, you are there? You wanted to take? What are all the top three differentials? The top three differentials will be narcolepsy, that is sleep attack, or he said daydreaming, that is also fine. But the most important differential diagnosis will be a complex partial. Can you play the video once again? I will play the video. Everybody is on mute. I am finding it very difficult to keep muting myself each one of it. You can see I'm just holding the child so that it doesn't fall. You can even mention that when you are just describing the video, you can see the mother also coming and supporting the child so that the child
From
is
the back. Right.
not falling down. But as you said, the child immediately regained consciousness. Almost. The child is now doing well. The child is on almost 1 year of anti-epileptics, and the child is seizure-free for past almost 1 year. The child is on valproate. Okay, thank you. We'll move to the next. Dr. Tanushree, you are there. You want to take the case? Next video?
Yes, sir, I can.
Okay.
Am I audible, sir?
Yes, you're audible.
தண்ணி குடிக்கிறீங்களா? தண்ணி வேணுமா? தண்ணி குடிக்கிறீங்களா? தண்ணி வேணுமா? தண்ணி குடிக்கிறீங்களா? தண்ணி வேணுமா?
Okay, sir. I can just start. I can see. Can I start?
Wait, please. Let me show for us.
தண்ணி குடிக்கிறீங்களா? தண்ணி வேணுமா? தண்ணி குடிக்கிறீங்களா? தண்ணி வேணுமா?
Sir, any age?
Age is 6 years.
Okay.
You want to start?
Pardon?
You want to start?
Yes, sir. I can start.
Okay. Even in the exam, if you're already ready, you have to wait for 3 minutes. The examiner will start only after 3 minutes. So till 3 minutes, how much ever time you want to see, you can see. And if you don't want to see also, you can stop the video and you have to keep seeing the examiner. He'll be quiet. Okay, you can start.
Yeah, I can. In this video, I can see a young boy, about 4 years old, who seems to be in the OPD setting. He doesn't have any devices around him. He doesn't have any dysmorphic features. He doesn't seem to be in distress. And he is responding to what the person in the background is asking him to do. What I can see, he's having bouts of cough, paroxysmal cough with characteristic whoops and but he doesn't seem to have any cyanosis, pallor, or choking. My differential diagnosis in this case would be probably pertussis like
I'm not able to hear you, doctor.
Okay, you haven't heard anything that I said, sir?
Yeah, you still pertussis like illness, I heard.
Okay. No, I haven't said anything after that.
Okay, other DDs?
Other DDs, he could be suffering from community acquired pneumonia, or it could be a upper respiratory tract infection.
Okay, others can put your DDs in the chat box. Yeah. Continue, please, doctor.
Yeah, others could be any underlying lung disease.
Okay.
Like cystic fibrosis, but this is unlikely since he seems to be quite well grown for age.
Okay. Keep talking, doctor. You don't pause at all in the video station. The more you talk, it more deep you put, it is better.
But will I not be prompted with questions rather than
No,
replying
you
on?
have to give your DD, then you'll be prompted with questions.
Okay, my DD, as I've said, is it could be whooping cough.
Okay.
It could be pertussis-like illness caused by other organisms like mycoplasma or adenovirus.
Okay.
It could be pneumonia.
Okay.
It could be upper respiratory tract infection. Yes.
Okay. What are all the history you want to get from this child?
I would like to ask about the onset, course, and duration of the illness.
Okay.
And is he having any associated cyanosis, pallor,
Okay.
any choking or any missed toys? And I'll ask him about the nature of the cough. Is it associated with is it episodic, associated with ropes? Most importantly, the vaccination history, whether he was vaccinated,
Okay.
particularly DPT.
So assume that this child has croup. What other points you will check in the examination to know that this is croup, to confirm that it is croup in examination?
Okay. Group. Group is associated with, I would, in examination, I would look for presence of stridor, inspiratory stridor, and presence of any increased work of breathing, cyanosis, then presence of any chest indrawing, if any. I would do a respiratory system examination in detail and ask and check the SpO2 as well.
Okay. Now assume that this child has pertussis. What are all the points that you'll ask for in the examination, see in the examination, clinical examination?
For pertussis,
Hmm.
okay, clinical examination, I would check the vitals, every breathing circulation as well as the oxygen
Any
saturation.
specific pointers to know that this is pertussis?
Okay, pointers. I would look for conjunctival hemorrhage if present.
Okay.
Then rectal prolapse, presence of faith cyanosis.
Okay. Okay. Assume that this child has wheeze. What are all the pointers that you look for in the child in if it is wheeze?
If it's wheeze, I would ask him whether if this is are there recurrent episodes similar to this? Is the child is it chronic wheeze or acute wheeze? And is it does it occur more at night?
Examination clinically.
Oh, clinical examination.
Hmm.
If it's wheeze, I will also look for. I will do a airway breathing circulation and check the vitals,
Okay.
as well as look for presence of crepitations and other findings in the respiratory system.
Okay. Okay. If it is a pertussis-like illness, how you are going to manage?
Sir, pardon?
If this is a pertussis-like illness, how you are going to manage this child?
What like illness, sir?
Pertussis-like illness.
Pertussis.
Yeah, pertussis-like illness. How you are going to
Okay,
manage this child?
Okay. First, I would like to take care of the airway breathing circulation.
Okay.
Then admit the child, isolation, and it is a notifiable disease, so I will notify, and also take care that there is no pregnant woman comes in contact with the child, and start antibiotics. Antibiotics will for less than 1 year, it would be azithromycin. For more than 1 year, it would be clarithromycin. We'll give it for 5 days, and also give prophylaxis, sir, to certain susceptible group. Prophylaxis with trimethoprim.
Okay, what advice you want to give the parents?
It is important for the parents to know the prolonged nature of the disease, that the cough may sometimes continue for days together. It is also called the 100 days fever. So parents should know about this, how it is transmitted, and the fact that the child should be isolated and away from the risk group, and also explain about the complication of the disease.
Okay. Okay, your time, sir. Good. You made a very good attempt actually. Your DDs were good. Any other DDs you could have added? Older child.
Yes, group I did not consider in my differential diagnosis, considering the fact that this was an older child.
Okay.
So in a younger child, definitely it would have been in the DD.
Foreign body.
foreign body is also something I did not consider because it was an older child, but
Okay.
it is always there in the. It should have been there in the DD. I should have included it.
Yes. Anything else specific? Did you see the type of cough? I'll show you once again. He's able to control the cough.
Yes, he's able to control. He's able to reproduce it. In fact, when the clinician
Yes.
is asking him to
So
stuff
any
it.
other cough you want to add? See, this is actually not proof actually. So this was actually a child with a postnasal drip, lot of postnasal drip, and as somebody has put, 2-3 people have put that it is most likely to be habitual cough also. When children is able to control, you can tell that it is habitual cough or a psychogenic cough. What is lacking in if you say that it is pertussis, pertussoid cough?
Pardon, sir?
What is lacking in telling that it is pertussoid cough? What aspect of cough is lacking if you are going to tell that it is a pertussoid cough? What is the criteria for pertussis?
So there should be a weight associated with post-tussive vomiting sometimes.
Okay.
And then the cough coming in bouts.
Yeah. So the cough should be for more than 14 days. You should have a cough for more than 14 days. And as many of them have put that it should be a paroxysmal ending in the woof. So that part is not there. So that part alone, see, when you're going to tell the DD, you may not be able to tell all the DD. So you can tell that. So this child has a bout of cough. So it has a paroxysms, but there is no woof in the end. So probably it could be a paroxysmal cough. I will also think in terms of upper respiratory tract infection, as you said, with the postnasal drip. I will also think in terms of stridor, but I didn't hear any specific inspiratory sound. I'll also think in terms of wheeze, foreign body. So that also can cause cough because he is a well child. I will keep pneumonia down the order because he is a well
Yes,
child.
as a top sick, yes.
I'll keep pneumonia in down the order. And I will also think in terms of habitual cough since he is able to control the cough a little bit. So habitual cough is nothing but psychogenic cough. Some people say they use the word psychogenic cough, but means he can able to control the cough. He can able to reproduce the cough, and when nobody is attending to him and he's quietly watching some TV or something like that, he's not having cough. Or if he's sleeping, he won't cough. So that point differentiates from postnasal drip. So postnasal drip, you'll get cough if you sleep. So how will you differentiate a cough of wheeze and postnasal drip, especially if it is there in the
Post-nasal drip, the cough will come as soon as the child goes to sleep.
excellent. So
Come in the beginning, and
yeah,
which will come usually if it's due to asthma or any other reactive AV disease. It comes in the middle of the night. He wakes up from sleep and then he has the wheezing.
early morning, excellent.
Yeah, early.
If it is before 12 or after 12. So before 12 cough is mostly because of postnasal drip, wet cough as somebody has said, and after 12 cough is mostly a wheeze cough. Okay.
Sir,
So,
in the middle of the class, I got the news of my daughter getting a seat in Chettinad Medical College. She just got a news.
I'll inform Balaji. I'll inform Dr. Balaji.
Yeah, I had taken his opinion earlier.
Yeah.
He has been allotted that college.
No problem. You can come back to us if she gets the transfer.
Yes, sir. She is very happy.
Good. So antibiotics less than 1 month is azithromycin and more than 1 month is clarithromycin. You said 1 year, less than 1 month is azithromycin, more than 1 month is clarithromycin. Rest all is fine. You mentioned about pregnancy, everything is fine. So this child could, this child is just one of my clinic patients. So I just want to keep some DDs. So I put this case. Okay. Your attempt was good. Any other points anybody wants to add? Somebody has raised the hand. Dr. M or somebody who have raised the hand. Anybody, any other points anyone wants to add? Or we'll move to the next.
Here, Doctor, most probable the diagnosis is you mean habitual cough, as the patient can control his cough.
Yeah.
Then I will put the croup.
Yeah.
After that, I can put foreign body.
Okay.
Okay. And as the patient is not toxic, I can exclude upper lobe pneumonia.
Okay.
Yeah, as he is not toxic, well, and as he is not toxic, I can rule out epiglottitis and tracheitis.
Tracheitis, bacterial.
Yeah.
Very good.
Yes, and I have to check if he has any previous history of intubation, subaglottic stenosis.
Yeah.
Can I put tracheal malaria or not?
Yeah. See, this is not a straightforward Strider case.
Not the Strider. Yeah.
If it is a straightforward, no. If he is having Strider, then you can put all these DDs. If it is a Strider, then you can put acute Strider or chronic Strider, as you said. So acute Strider and chronic Strider will come. All the 7-8 causes of acute Strider and 7-8 causes of chronic Strider. But here it's more of a pertussoid cough. It is less of Strider than more of pertussoid, as somebody as Dr. Hamdan has put it in the chat box. So as she said, I will also put a pertussoid cough as higher in the order, except for the part of the wound. So it is less of Strider than more of oof. So that the last oof part alone is not there. So you can put habitual cough higher up in the order. And as you said, pneumonia.
Pertussos, I think it's unlikely.
Unlikely. Yeah. See, the examiner wants you to discuss, that's all. So this may not be the typical case in the MRCPCH exam, but the examiner wants you to discuss. So in the time, and that's why I told her, keep talking. So you tell the examiner, sir, this could be a possibility, this could be a possibility, this could be a possibility. The examiner doesn't want a consultant there to get passed. He wants a ST4. He wants a safe pediatrician who will think of all the causes. Okay, so you think of all the causes and you tell him that I'm ruling out this, I'm ruling out that, I'm ruling out this. So that's how you approach. So he won't penalize if you don't tell the correct answer. Okay, if you give 4-5 DDs, your DD is down the order, and he will tell you, okay, suppose if this is pertussis, or suppose if this is foreign body, then how will you proceed? So he will have the key for that. So then you should consider that, okay, that is probably the diagnosis here. And he won't penalize you for that if you are going to tell your differential diagnosis. But think if somebody tells that this is bronchiolitis, okay.
No.
Yeah, then
it's not the age.
Yeah, this is not the age. So then he's going to start penalizing you. So you should not do some blunder. That's all. You can say this as a Strider, but still it is not a clear-cut Strider. It's fine. You can say this as a postnasal drip. You can say this as a wheeze, or I just want to confirm all this. But you should be discussing the pros and cons for the DD. That's all. So that is what the examiner wants. Good. Thank you. So,
Sir, I have a question.
Yeah, please.
Sir, you asked one question, how you will differentiate on basis of examination if this is group, this is pertussis. Yeah. One is subconjunctival hemorrhage or petechial hemorrhage.
Yeah.
What about in group? What specific finding we'll find?
Yeah, she said no, in group, you have a group score. You should look for cyanosis. You should ask for you should see for increased work of breathing. So you should see whether it is inspiratory or expiratory. Is group inspiratory or expiratory?
It's inspiratory.
Yeah, it's inspiratory. And if it becomes expiratory, if it is become biphasic, then it is a significant. It means
increase the severity.
Yeah, it means there is a severe. Similarly, if wheeze is always expiratory and if wheeze become inspiratory, then it is severe. So you have to check all these clinical points. That's what I wanted from that. And then you ask, you see whether she has drooling and whether she keeps her neck retracted, whether she's drowsy. So all these points will be what you are looking for in the examination. So the examiner wants to know whether you know all the DD and whether you know what are all the red flags that you want to check. That's all. Good question. We'll move to the next scenario. This I have taken from, this is not my personal case. I've taken from YouTube. Who wants to attempt? Somebody has put in chat box.
Yes.
I'll give it to the floor. Who wants to attempt? Raja wants to attempt. Okay, you can go ahead and attempt. You can open your mic.
It's open, Dorito.
Okay, your time starts now.
It's a video, yeah?
Yeah, it's a video. I'll show you one second. We'll start the timer.
वापस आओ मेरे पास आओ भाग के आओ भाग के
फिर से चलो ठीक हो जाओगी फिर से चलो
भाग के जाओ वापस आओ भाग के आओ भाग के बाबा के पास जाओ चलो वापस आओ भाग के आओ वापस आओ मेरे पास आओ भाग के आओ भाग के
फिर से चलो ठीक हो जाओगी फिर से चलो
भाग के जाओ वापस जाओ बाबा के पास जाओ भाग के
The right is she has special shoes in the right side.
भाग के आओ भाग के
Wait.
No, no.
Your 3-minute time is not over.
फिर से आओ फिर से पैसे ज्यादा दूँ
चलो वापस आओ भाग के आओ वापस आओ मेरे पास आओ भाग के आओ भाग के
फिर से चलो ठीक हो जाओगी फिर से चलो
भाग के जाओ वापस जाओ बाबा के पास जाओ भाग के
How old is she?
She is 4 years.
वापस आओ
4 years.
भाग के आओ भाग के बाबा के पास जाओ
फिर से आओ फिर से पैसे ज्यादा दूँ
चलो वापस आओ भाग के आओ
One more time. I will show.
वापस आओ मेरे पास आओ भाग के आओ भाग के
फिर से चलो ठीक हो जाओगी फिर से चलो
भाग के जाओ वापस जाओ बाबा के पास जाओ भाग के वापस आओ भाग के आओ भाग के बाबा के पास जाओ
फिर से आओ फिर से पैसे ज्यादा दूँ
चलो वापस आओ भाग के आओ
Okay.
I can see a 4-year-old female. She is a clinic at a setting. She is really grown for her age, not attached to any devices, but she has, I think, special orthosis in her right foot. She is really grown for her age, not where she doesn't have any dysmorphic features. She has gait. She has fixed her arm, right side arm. It's not fixed to her body, not moving well, with stiffness of her right hip, knee. So it is a case of spastic gait, hemiplegic gait, right side hemiplegic gait.
Okay.
Okay,
The hemiplegia of which side?
of right side.
Okay. So, what are all the differential diagnoses you want to give if it is a hemiplegia?
It may be a differential diagnosis, spastic hemiplegia,
Okay.
and maybe double plegia, but the other side is old and already done for it physiotherapy.
Okay.
Yeah, and for differential diagnosis, the cause may be a stroke, tumor, vascular, thrombotic and vascular stroke.
Mm.
Yes, tumor and intracranial hemorrhage due to any blood disease that cause this condition,
Okay.
and bleeding tendency that cause this condition.
Okay. See, suppose you want to localize the lesion. What examination you want to do? What other examination you want to do in this type? You want to localize the lesion.
Please, again, the question, because I can't hear you well.
You want to localize the lesion. You want to know where the lesion is. What other examination findings you want to do?
Yes, I want to do a full cranial examination.
Yes. So, any specific
Yes,
kind of-
yes, Amir. Glasgow is here. Yes, and examination. I want to see if there is facial asymmetry and eye involvement, and I have to do full neurological examination for body examination, tone, power, reflexes, sensation, and Babinski sign coordination. Yes. This is another examination. In addition, I have to do, she may need, I have to revise her notes. If the neuroimaging not done for her as a brain CT scan and MRI, I have to involve the consultant and the neurologist or do this neurological examination. And to
from the video, do you think it is an upper motor neuron lesion or a lower motor neuron lesion?
Yes, it is upper motor neuron lesion, of course.
Any specific reason you are telling because from the video?
From the video, she has not swinging, a fixed right arm. It is flexed to fisting, and she has fisting, and she has orthosis and if hyperextended knee and hip joint.
Okay.
And already she is cooperative and alert.
Okay. So what any provocation maneuvers you want to do to make
a provocation test. Yes, I have to tell her if she can walk in her toes and heels, and if she can run and to walk on the both side of her feet.
Okay, good. So how do you want to manage this child?
Yes, this patient I have after revising her notes and do full examination for her, I have to involve multidisciplinary team as a neurologist that she may have seizures to control her seizure if there is, and I have to involve the physiotherapist and the occupational therapist to maintain her daily living and to try to let her live independent life as much as possible. And I want to check if there is any speech difficulty or swallowing difficulty, but she seems not to have. I have to involve the SALT and speech and language therapist, and I have to involve liaise with a future educational healthcare plan for school to make a convenient school environment for her. And I have to involve social workers, and that she may need easy access to hospital, support them psychologically, financially for the family and for the child.
What will be the prognosis in this child?
Prognosis, if she is compliant to treatment and physiotherapy, she has good prognosis as she has good mentality.
So what will be the prognosis depends mostly on?
The sound is not. I
No.
can't. Yeah. Excuse
prognosis,
again.
Your
Yeah.
prognosis will depend mostly on what?
The according to the region, according to mentality, and according to the how the child and her family strict with the physiotherapy and occupational therapy, and as much as they do it in everywhere at the home school,
Okay.
she may have as much independent life for her.
Yeah, good.
And
So,
depend of course on the cause.
Cause, exactly. So it's most likely, see, suppose it is going to be a homocystinuria or an infective endocarditis or a nephrotic syndrome. So some recurrent causes, it may be difficult. We don't know. So
Yeah.
You have to, it depends on the other systems also.
On the cause, yes.
Yeah, good. So very
Great.
good attempt. Anybody wants to add anything? You explained the gait well. You explained about the arms being not moving well. Then you said the provocation and you said almost all the causes. Facial nerve examination is very important. That you brought out very well. And musculoskeletal system examination also is very important. So you want to know whether she has contractures. Okay, so
yeah,
that is also very important. You have to release this tendon, the tendo Achilles.
yes, for the spasticity, you can,
Yeah.
I can, if the for spasticity, for
Yeah.
yes, physiotherapy, non-medical approach, which
Yeah.
is physiotherapy and occupational therapy, and I can go for medical therapy as
So in the
Gonadine.
examination, I wanted what else you want to do in the examination. You said the tone, power, reflexes. So
Yeah.
I wanted you to tell about the contractures, and I wanted you to tell about
Okay.
the spine and put the Royal College examiners are very particular about the spine. So spine and foot, you have to see the back and you have to see the arch. The two arches, one in the back and one in the foot. So you have to be very particular about the spine and the foot. Rest all is fine. Your approach was fine. Anybody wants to add anything? People have put in the chat box underlying etiology, right side hemiplegia with same side, probably facial or palsy, CNS examination, CNS cranial examination. So they were all correct. Okay, good. Very good attempt.
Doctor, you mean I have to do full musculoskeletal examination? That's what you are mentioned.
Yeah,
and
yeah.
I have to check if there is any scoliosis and the back arching also.
Yeah.
Okay. Yeah. Thank you.
Thank you. So who wants to take the next case? Dr. Ikra. Somebody. Dr. Ikra wanted. Anybody else wants to take the next case? Dr. Aisha, you wants to take the next case?
Okay, doctor.
Okay. You're ready?
Okay. Yeah.
Very good. Dr. Aisha is very brave actually. She to take in front of so many people, and she's very thorough. She's very good in her approach. We'll see. A very easy case. Last case is a tough case. Let's see who wants to take the last case. Your time starts now. You can start the question.
Okay. I can say a young baby who's crying in a weak cry with a prominent lesion in her upper lip, could be hemangioma. I don't know what is it a traditional mark on her upper head, or it's a birthmark?
Okay. That is
But
what they do in South India.
okay.
Ward of evil eyes.
What, doctor?
To ward off the evil eyes, they put that tilak. Yeah.
Yeah. Okay, I get your point. Okay, so my differential diagnosis is hemangioma or phases to look after if there is an internal hemangioma that can cause this weak cry, and I want to look at the I want to know if there is what is the progress of this lesion, is when did it start and how it progress, increasing and decreasing manner. Did the patient receive any medication during this period to improve it? And what if she has any hematological disease and associated symptoms of the respiratory symptoms like shortness of breath and apneas, or if she has any abdominal cramps.
Okay. Suppose you assume that this could be a hemangioma. What are all the differential diagnoses, or what are all the associated syndromes that you know with hemangioma in such a young child?
Okay. Yeah. So there is phases, and if there is Sturge-Weber, simple hemangiomas, or complex, the one with Burkitt, I forgot the name.
One which comes in the newborn, which consumes coagulation factors.
Yeah. Kesselbach.
Kasabak. Okay, good.
Okay. Brad.
Okay, so
Beckwith-Whitman syndrome.
Okay. Suppose you assume that this hemangioma is in a very critical phase,
Yes.
and the child is very young. Okay. So what are all the stages of a hemangioma? Others can type.
I don't remember.
Okay. So at this young age, and this child has a very big hemangioma in the mouth. And how do you want to manage this child?
Yeah. We have to look after the complication, which might be like internal hemangioma. So we have to ask the ENT evaluation for endoscopy, and we have to look for the internal hemangioma, like in the abdomen, for the liver, for example, and do abdominal ultrasound. And sometimes it happens in the brain, so we have to do a brain ultrasound or CT.
Good. And
the blood workup for a coagulation and bleeding disorder.
Any drugs? Do you want to
we usually
drugs, or you want to wait?
Usually we are starting propranolol as early as possible, which can regress the progression of the hemangioma and help it to decrease and improve as a mark as well.
What are all the ways you can give propranolol?
Oral
Okay.
can be given.
Okay.
Depend on the age, and we are increasing with the weight.
Okay.
The dose will be increased with the weight.
Okay. If propranolol is not working, can you name any other drugs?
No, I don't know. We usually sometimes they laser, but I'm not aware of another drug.
Okay. So suppose this is in a non-threatening place. It is there in the chest, very small hemangioma. So what will be the advice you'll be giving to the parents?
Okay. The advice that they have to know what is the size start with and how it will progress, and if it respond to medication, and if it increase in size, or they saw it multiple areas, or it grows in another areas, they supposed to seek medical advice. Or if it's showing in airway, they have also to seek medical advice.
Okay.
Or sometimes it get ulcer, so better to be seen and take care of that. Also, it might get an infection, so better to be treated with topical antibiotic.
Okay. Your time, sir. Good, very good attempt. So you almost told all the syndromes associated. Clipple Tranonoi alone you didn't say, but that is okay. You mentioned all the syndromes, and there are three phases actually. One is the flat phase, then the growing phase, which usually happens after 3 to 6 months. And after 2 years, the involution phase starts, and by 4 years, it usually disappears on its own. But hemangioma in very critical places, like the lips, like in the tongue, like in eyes. So then you have to intervene. You can give topical timolol. Timolol gel can be applied. You can give intralesional propranolol, or you can give steroids. Then you can give your interferon alpha. So these are the new drugs that we are trying. Laser, you said it is fine. And the advice is that you should avoid trauma. So this child will have trauma when you are going to feed the child. So that's why you have to intervene in this child. Definitely you have to intervene in this child. So advice till surgery, you can tell the mother to apply Vaseline. You can ask the mother to cut her nails so that she will not inadvertently touch it and open it. So these are all some kind of advice you can give. Somebody has said that it could be angioedema. It is very unlikely to be an angioedema because it causes swelling of the entire lips. So it is very, very unlikely. Vincristine, I don't know whether they are using vincristine, but this is not a place where you wait for spontaneous involution. Even my pediatric surgeon, even if it is in the abdomen, he wants to start propranolol. He says you want to avoid all ulceration, all these things. So Kasabach-Merritt syndrome. And somebody has said that it could be a lipodermoid, or it could be a sebaceous cyst. You can tell some gross DD like that, it is okay. But this is very clear cut. Sebaceous cyst is also a midline swelling, but there is no punctum here. It is not black in color, and it is very reddish, cherry, strawberry in color. So then you have to go for a strawberry nevus. So good, very good attempt, Dr. Aisha. Thank you. Who wants to take the last case?
So can you just revise the treatment for this? What?
Treatment, see, treatment is necessary only if it is going to be in the critical areas like in the lips, like in the eyes, or like in the tongue, or if it is going to be in the, as she said, in the vocal cords. So then you have to treat the child. So if it is in the face, you always screen with a cranial ultrasound, you do an abdominal ultrasound, you do an echocardiogram, and you do an upper airway examination. So you do all these things. And if it is going to be in the critical area, then you always start on drugs like oral propranolol, intralesional propranolol, topical timolol, or you can give steroids, oral steroids. Then you can give interferon alpha. So all these are all laser therapy. So these are all the treatment of choice. So then you have to look for complications like ulceration, bleeding, and the causes, as she said, it could be a Stooge-Weber, Casa-Bach-Merritt syndrome, and Klippel-Trenaunay syndrome, and Faces syndrome. So these are all the causes. Somebody,
Thank you.
what about steroid? Yeah. So what would be the top DD? The top DD is hemangioma, and I will say, I can say that it could be sebaceous cyst, but it doesn't look like a sebaceous cyst because it has no punctum. It is very red in color, strawberry in color. So I'll keep that down in the order. I dentigerous cyst also, but it is not appearing to arise from the alveolar area. So it is more upper, it is arising from the lip. Like as I said, you can give a meaningful discussion. Suppose if somebody says that it is angioedema, then the examiner will be a little annoyed. So other things and all is fine. But you have to stick on to hemangioma and start discussing the etiologies, that means the syndromes associated with hemangioma and how we are going to manage the hemangioma. Who wants to take the last case? Last video. Some brave soul. Dr. Namrata and Dr. Ikra said, I want to try, please. Dr. Sindhu, you are there? You want to take the last video? If nobody wants to take the last video. Srikanth, you want to take the last video?
Sir, actually, I'm not in out of station, sir.
You are out.
I'm not going to take.
Okay.
I can try.
Who wants to try?
It's Dr. Tanushree.
Dr. Tanushree again. Okay.
But if there's anyone else, I can always.
No.
Dr. Raja has raised her hand, and some new people coming out.
I left for anyone, not.
Munir wants to try?
Yes.
Yeah, okay. So, where are you from? Dr. Munir, you are from which place?
Yes, I'm from KSA.
Okay. Okay. Your time starts now. Good. 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 You want to see one more time?
Yes, yes.
Okay. Good.
Okay, okay, doctor.
Yeah, please stop.
Okay, how's the age of baby?
He's a 7-year-old boy.
Okay, 7-year-old boy. This is been examined by eye movements. Okay, and maybe in the hospital OPD setting. I can see baby is not dysmorphic. He's uh, average for weight and height, but I want to make consent height charts. Okay, this baby is looks okay, but during eye examination there was some problem in the eye. He has a squint. It is clear. On the right side, there is a ptosis on the right side, and child is unable to move his right eye towards the left side, and it's looks like horizontal squint because right eye is unable to move medially. It's medially is unable to move laterally. So on the basis of this, I can keep this patient have I think maybe involvement of this one. This, you can say it's either this is Thorner palsy, either Thorner palsy. I think
What palsy?
this is Thorner palsy.
Okay.
Okay, and because this child have only squint, although I didn't find any facial asymmetry
What is the
into the
test?
scope.
What is the test that the examiner is doing?
He was doing examination for eye movements for squint.
Any specific name you give for the test?
Is the name this is cover uncover test really.
Okay.
So this is the test being performed for eye examination, eye movements. Okay, so to see the squint for eye and problem in the eyes for nerve palsy especially.
What is the type of eye problem that you see clearly in the video?
Clearly in the video, there's right ptosis.
Okay,
And,
right process is correct.
yeah,
Then
and he was unable to move the right eye properly, medially, and
others can put it in the chat box. Okay. Yeah, please.
so on the basis of this, what other question you want? You need the differential diagnosis. I can keep it. This is right cytosis. This may be congenital or some.
Okay. How do you want to manage this child?
Managed, and definitely I will go to examine child completely. This eye examination, I will enroll the ophthalmologist to examine this child, complete eye examination, including fundoscopy. I will do complete neurological examination also, and also I will take history from this child, how's the duration of this course progression and the onset of this, and any steps taken before, any management or any investigation done before. And I will also know the management depends upon the underlying cause. It is if it is acute problem, I will enroll the ophthalmology, and then if it is some congenital or some problem, or that's I will treat according to enroll the ophthalmologist for this further treatment of this problem.
Okay. Okay. So, any specific treatment plan you want to give? Any drugs?
Yes, drugs, basically it is depend upon underlying cause. For drugs, I will go to prevent the exposure keratitis. I will artificial tear drops,
Okay.
sometimes eye patches to prevent from the keratitis, exposure keratitis.
Good.
And I will enroll the physiotherapy for this physiotherapy for this problem. And then sometimes during sleep there should be eye patch during sleep to avoid the keratitis.
Okay.
This is the main. And if there is any problem in the VN, reflective errors, I will take ophthalmology opinion or if he need any ear glasses or some other things.
Okay.
Anything?
Okay. So what is the prognosis here?
Prognosis, sir, this depends upon the underlying problem. It is congenital weakness of this nerve or muscle. It is depends upon the
Suppose you
operation.
assume that it is congenital.
Then this prognosis is not good. Yeah, it will go for lifelong. But if it's acute problem happen to an acute insult, prognosis is good.
Okay, good. Okay. Thank you.
This is a really difficult stage.
Really difficult stage. That's what I told you. You should be brave to take up this really difficult stage.
I was brave to take this stage.
Yeah, yeah.
Nobody
You
was
see,
willing.
I used to tell in my class, whoever attends the long course with us, one who takes without any inhibition and gets all sorts of this bouncers here will get extra 5 marks in the exam. So they will do well in the exam. They will try to face the challenge. They are here trying to face the challenge instead of hiding. So all these people who are attending our...
Can I try once, sir, the initial part?
Yeah, you just describe Dr. Tanushree.
Yeah, this is a child in the OPD setting in whom alternate cover uncover test is being done.
Okay.
He has got manifest squint, which is quite obvious. And while doing the alternate cover uncover test, we can see that he has alternate exotropia of both the eyes. As I can see that the eyeball is moving from outside to inside. Yes. When the eyes are focusing, when one that is what I can see in the video. So in this child, he will require first they will try correction with glasses.
Okay. I agree that he has alternate. He has both the eyes exotropia. Yes. Some people may not agree. In the chat box, they have not put both the eyes exotropia. But why don't you agree with the ptosis on the right eye which he mentioned? Can you now see the ptosis on the right eye which he mentioned?
Again, the test, doctor.
Yes, I agree with that also. I just
yes, doctor, I on the right side.
Yeah. So
on the side there's ptosis.
That is the reason for his
small iris.
One at a time. Dr. Tanushree, yeah.
In this, if we can have a video where the proper eye movements are also assessed, then we will be able to appreciate whether the ptosis is due to a third nerve palsy, which will give rise to a paralytic kind of squint.
Yeah. So, but as you said, there is an alternate cover uncover test one, and both the eyes as he has exotropia and he has right eye ptosis also. You want to add something, Dr. Raja?
Doctor, yes, doctor. Thank you. But here I can see as you mentioned, right ptosis, right?
Yes.
And I can see enophthalmia, small iris enophthalmia on the right side.
Yes.
So I put on my differential the Horner syndrome. So I will check hydrosis of the right side. And with cover and covers test, I can see exophoria, not tropia. Tropia manifest squint. You see with cover and cover test, yeah, his eyes, when you uncover him, his eyes, the left one, go from outside to inside, to the center. Am I right?
Yeah.
So it is latent squint. So we can't give it the name tropia, phoria, exophoria.
I beg to differ. This is not a latent squint. This is a manifest squint. We can easily say that both the eyes are not aligned. First of all,
even when you are not covering and uncovering this, doing the covering and uncovering, that is what Dr. Tanushi wants to mention. But in this video, it is not very clear. But when you see him on the in the clinic, you'll know that he has a manifest. It's not a covered squint, so you can easily see that. That is true. You can argue like that, but what I will give you, I will give is probably a trophia than a phoria. Okay, so
is now is squinting without covering.
I didn't get you.
Is it manifest or latent now?
Well, you want to know, is it a manifest or a latent?
Yeah, is it manifest or latent squint?
What do you think?
I think it is latent, not manifest. Now the two pupil are at the center.
Yeah, that's what we are telling. It is mostly a tropia than a phoria.
Phoria means latent. Phoria latent. Manifest, as I know, I am not sure. Tropia means manifest.
This is
right?
manifested now. When we see in this case now.
Just open your mic and dance.
Like in this, before we have started the cover uncover test, we can see that the right eye is laterally deviated, right?
Yeah.
So this is manifest. Like trophia, not phoria. Before starting the test, we can see that the squint is there.
Manifest,
then
yes.
We'll start. Yeah.
So more likely to be a trophia. Oh, I said the other way. So more likely to be a trophia than a phoria.
Right, sir.
Yeah.
This is what I also think.
And don't miss the ptosis on the right eye. Even the mother of this boy has a squint. I have the video of the mother of this boy also. So even the mother of this boy has squint. Okay, so we are already 1.5 hours. Okay.
So what is the best course of action if it's a congenital squint, sir?
Surgery. So he's see, till 2 years you can, up to 2 years you can wait. So after 2 years, you advise them to go for surgery. This child came very late to the hospital, and the surgery was very difficult for him. So they didn't take up the option of the surgery. The child has some glasses. The ophthalmologist has suggested some botulinum toxin also for the child, but they have not taken up botulinum toxin also. Some form of remedial measures till the child goes for a surgery on the right eye, they can give botulinum toxin, it seems. So all cases except the one for the gate is from my OP. So I thank all these children You know how difficult it is to take the video of this child because he has to focus. Whenever you do ophthalmological examination, you are given a task in the clinical in eye examination, and you are going to do a cover and uncover test. Make the mother stand at the one corner of the room, ask the child to look at the mother, and then you do the cover and the uncover test. If the child keeps looking at you, it is very difficult to do the cover and uncover test. So here I made my staff to record the video on the other side and make him look at that, and I brought the note in front so that you will see the cover and uncover test properly. Okay, we'll have one more session next week. I hope it was useful.
So another question I need to ask.
Yeah.
If we see a 3 or 4 month old baby with squint,
okay,
what advice should we give to the parents?
Yeah, they usually you send them to a pediatric ophthalmologist. They advise correction by 1 year. So by the time the child starts fixing properly, so you try to get a pediatric ophthalmologist. That will be around 3 months or 4 months. They usually advise corrective surgery around 1 year. When the child gains some approximately 7 or 8 kgs, then they advise surgery.
So don't they also have physiological squint till about 6 months of age?
They have lot of investigation and tests now to differentiate physiological and pathological symptoms. So it all depends. That's why they wait till 1 year. So after that, they usually go for an early correction because you can get refractive errors, and later on surgery is little difficult if it is a manifest squint like this. So we'll come to an end. We'll not have more recording space. We'll have another class next week. You all please join, and do please watch our videos in the YouTube channel. And please put your comments in the group. So long course people, you can join for the next class. I think it is on Friday. We'll have the next class. Oh, sorry, today is Friday. Okay, next week schedule, we'll put it soon. Okay. Thank you. Thank you.
Thank you, sir.
Thank you. I will share the link for the channel in the group. We'll share the link for the channel in the group.
Sir, please send the link for this class also. I could not attend it.
Sure, I'll send the link for this class also.
Thank you, sir.
Thank you very much, sir.